I have the pleasure of introducing our next speaker. Our next speaker is Colton Johnson. He's a clinical physical therapist with Avera Therapy in Sioux Falls. He specializes in neurological rehabilitation with a special interest in concussion management and vestibular therapy. He is certified in BIG and POWER for Parkinson's-specific care and is actively involved in programming for Parkinson's, MS, brain injury, and spinal cord injury. Colton is passionate about helping patients move better and live more fully. He also enjoys mentoring the next generation of physical therapists in neural rehab. Please help me welcome Colton.
Thanks. Okay, there we go. Sorry, I'm not very good technically. So like I said, yeah, I'm a clinical physical therapist. I work for Avera Therapy. We work on a multidisciplinary team that makes up PTs, OTs, and speech therapists. We work with people with all sorts of conditions, but the main one that matters to you guys is we work with a lot of people with Parkinson's disease, okay? So just a disclaimer to start off, this presentation isn't meant to be a deep dive into all things dizziness, but more of just a general explanation so you guys can learn something about what may be occurring in you or your loved ones, so you guys get a better idea of how to care for them or kind of how to move forward with life. So ultimately, if you are experiencing any symptoms of dizziness or things like that, mention it to your healthcare team so that it can get appropriately addressed. Don't let those things kind of go on by. So a little bit more about me. You'll see a lot of pictures of my dog up here because he's pretty cool. So when I'm not at work, you'll find me hanging out with my dog or my fiance. My dog loves to jump in the water. All these pictures of him are him jumping off a dock into a pool for a toy, and he's pretty good at it. He's the #1 golden retriever in the world, so no big deal. And then, of course, bottom left picture is me and my fiance with our golden pup there. So, and here pretty soon, we're actually going to be welcoming another pup to the family. So, going there. The other thing that I think is important for you to know about me before we get going too far is I'm not only a healthcare provider for people with Parkinson's disease, is I'm also a loved one with people for Parkinson's disease. So, this is my dad, Jason. My dad was diagnosed with Parkinson's about 5 years ago. I was in my second year of PT school when he was diagnosed. He would be considered a younger diagnosis. He was only 52 at the time. Don't worry, he's doing pretty good. He actually has bilateral deep brain stimulation implants. He still works full-time, lives life how he wants to, rides his Harley around, kind of does what he wants. But just know when I'm speaking to you, it's not only from the perspective of a healthcare provider, but also as someone whose family and loved ones live with this diagnosis as well, even when he isn't taking my advice about what to do. So let's go through some just objectives. This is what I'm hoping that you guys will all be able to gain by the end of our presentation here. We're going to kind of just do a general overview of the central and peripheral vestibular anatomy and function. And so the vestibular system, we'll go more about it, is really, really important in how your balance and dizziness is impacted, and especially in Parkinson's disease. So, and then we're going to explore the interplay between different sensory systems and how that may or may not impact you. And with specificity to how Parkinson's disease affects that as well, okay? If you guys have ever seen It's Always Sunny in Philadelphia, you know that Charlie here, this is basically what I look like when someone comes up to me and says, well, I'm dizzy, and it's like, well, this could be 1 in a million things, so what are you talking about? And it's really, it could be 30 things contributing, it could be one thing, it really just depends on the person. So what does being dizzy mean? If I asked 20 different people in here, what does it mean to be dizzy, I would probably get 20 different answers, okay? You may be talking about the same thing, but you have a different word to describe it. So that makes our job kind of much more challenging to figure out exactly what type of dizziness are you experiencing and how can we best aim to tackle that and improve it so you guys can feel better and live better. Some common words that some people describe that you may connect with as well is, feeling lightheaded, nauseous, feeling off, like you had a little too much to drink after the bar, feeling unsteady, like you're standing on a boat. You might feel like the world is spinning around you or that you're spinning. Might feel like you're falling. There's many, many different ways to describe being dizzy. Okay, very simple overview here. If you guys are any familiar with the inner ear is what we call the vestibular system. So it's a tiny set of canals that sit right behind your eardrum, and it's responsible for feeding information to your brain about your head's position in space, okay? Depending on your head moves, it gives information to the brain. It says, oh, my head is turning to the left, right, so on and so forth. This is the system that helps keep you upright when you walk to the bathroom in the middle of the night with no lights on, okay? And you'll notice, use my fancy laser pointer here, there's these yellow nerves here that are very close to each other. They actually run right along next to each other, and they come from the same spot off the brain. It's called your vestibular cochlear nerve. One of them is your vestibular nerve, the other is your cochlear nerve, and so the vestibular nerve is how your balance is fed into the brain, and the cochlear nerve is how your hearing is fed. So the reason that's important is because that's kind of what makes sense if you have an ear infection or if you have seasonal allergies. That's why you might feel a little unsteady, a little off balance, is because they're so close in proximity to each other that they kind of affect each other too, okay? The other thing to note is this tube right here, the thing got cut off, but that's what the eustachian tube, so that kind of connects into the back of your throat where sinus drainage, all that stuff comes from. So if you're really plugged up, you might feel a little unsteady too, because it's all interconnected, okay? The other thing to note about this system is it works very closely with your eyes as well as the nerves in the rest of your body to feed information to your brain about your balance, your position, your movement, and it's a very, very complex interplay, and we'll kind of go a little bit more into that. Moving on to central, so I forgot to say, the last one was peripheral, which means outside the brain. This is central, which means the brain itself. The way I like to think about it is a little like a computer. So the peripheral is the mouse, the keyboard, the thing that gives information to the brain. So you can run the computer, and the brain is the computer. It processes the information and gives you the result here, okay? You may notice on kind of right here, this thing that says VN, that's the vestibular nuclei. So that's where the nerves originate off of the brain, or the brain stem, and feed back into the brain too. And it's very, very close proximity to centers where your vision is processed, as well as sensory processing, and it's very close to what's called the thalamus, which is kind of like the relay center of the brain. That's where everything kind of goes in and out of with the brain. It's kind of just a big toll system with the brain. So when you hear me refer to anything central, just remember brain or spinal cord related, nothing else, okay? All right, so this is what we call like normal sensory integration. There's a very complex interplay here, but basically your eyes, your vestibular system, in this case I just have a picture of an ear, and the nerves in your feet or in the rest of your body all work together to provide information to your brain that keeps you upright, keeps you moving, and helps you kind of process the world around you, okay? When all that works great, it's great, everything's in balance, but as we all know that things aren't great all the time. And so what can happen is we can get what's called peripheral dysfunction. This is when the eyes, the ears, the nerves, and the rest of our body don't feed the appropriate information to the brain. And I may have failed math class, but hopefully you guys didn't. When you have the wrong information, you're going to get the wrong answer, okay? In our case, that's going to lead to dizziness, okay? And this is what we would consider like peripheral-based dizziness. It's an issue that's not related to the brain, it's related to the information going into the brain. Okay, now that we talked about peripheral dizziness, there's the potential for central dizziness or central dysfunction. So the brain is receiving all the appropriate information, much like me in math class, but it uses the wrong equation and can't figure it out, and then therefore you get the wrong answer, or dizziness, or imbalance. Imbalance and dizziness are often interchanged with the two, okay? And just because we can't have nice things in life, you can get both at the same time. And then it becomes a really big puzzle of what is going on. So you're getting wrong information, that wrong information is also getting wrongly processed, and now you're really dizzy, okay? And unlike most scenarios, two negatives don't make a right here, okay? Two negatives just make a much bigger negative, okay? So this is just in general how our brain processes movement and what may or may not occur with dizziness. And then our goal, and kind of the point of all you being here today, is to relate how it relates to people with Parkinson's disease. And so we're going to try and break that down into a couple categories. Keep in mind that these categories here on the screen are not scientifically established in the literature as this is kind of what we go by. This is just how I think about it and how I explain it to my patients so that it might make a little bit more sense, okay? So the three categories here are what we would consider primary associated, secondary associated, and comorbid or other, the things that have nothing to do with it but happen anyway, okay? And just, I want to be clear on this, you can have things related in any of these three categories and they could all be occurring at the same time. So again, this is a very complex thing. We're just hoping to simplify it a little bit. All right, primary associated dizziness. So this is dizziness that is directly associated to the disease process that is occurring with Parkinson's disease, or direct results of that process, which, just as a short review, we all know this, it's a loss of dopamine in the brain, specifically the substantia nigra in the basal ganglia, where your brain kind of processes movement. But your vestibular system also plugs into that too. And so therefore it can impact the vestibular system and therefore your balance and or dizziness. These are all studies that have basically happened within the last 5 years where I'm getting a lot of this information. So we know that there is a 2 times higher rate of concerns of dizziness in people with Parkinson's disease. So there must be something related to Parkinson's that is making people dizzy that is not related to anything else. And so when we further explore that, they do find through what's called VMP testing or video nystagmography, where they actually test the nerve firing of your vestibular system, that there's dysfunction with that system in people with Parkinson's compared to age-matched controls, other people your age who may or may not have other conditions going on, okay? And imbalance, which can contribute to dizziness in persons with Parkinson's disease, is a direct result of the inability to effectively interpret vestibular information due to the loss of dopamine in the substantia nigra. So just to make that a little simpler, wrong information, this is a peripheral dysfunction. Your brain is getting the wrong information and doesn't know how to process it, so it's leading to imbalance and dizziness. So we're getting a peripheral issue here. And then we also see that there's alterations of vestibular activity increase across the lifespan of Parkinson's disease. So again, we know Parkinson's is progressive, and so the same goes with the vestibular dysfunction, is that this is going to possibly progress for you over the lifespan as well. And then vestibular processing deficits in the brain. There's a huge, huge link to that in freezing of gaits, which I know both clinically and for a lot of patients can be a very debilitating symptom of Parkinson's. And that's a central issue. Your brain isn't processing the information appropriately. So with Parkinson's, we're getting both the central and peripheral dysfunction. You're getting the wrong information and you're getting the wrong processing occurring, which is leading to quite a bit of dizziness or imbalance. And it kind of comes with the rest of the symptoms of Parkinson's, the freezing of gait, the rigidity, difficulty dual tasking, stuff like that. The other thing that is common, and we don't entirely understand, but we know a little bit about, is what's called dysautonomia. Some of you may have heard your doctors talk about this, and basically it just means dysfunction of the autonomic nervous system. And your autonomic nervous system is what's commonly called the fight or flight system. It's what happens when you run into a dark alley and there's a rabid dog there, that you kind of just, eyes blow up, your heart rate increases, your breathing increases because your brain or your body's trying to protect itself. So, and that happens throughout the day. And this dysautonomia just basically means that this system doesn't work how it's supposed to. So you might get appropriate increases in one area, appropriate increases in another, and then inappropriate changes in other areas. And so you get a whole mess of things that are occurring at the same time. And the most common complaint of dysautonomia is lightheadedness. I stand up too quick, I get really dizzy, and I fall. And that's where most of the people I see is because they have to fall. So that's where we got to look at it. There's varying levels of it. People may or may not develop this throughout the lifespan. Some people do, some people don't. It's hard to say. Some people have it with different levels of severity. And so it's really, really difficult to say. It's just person-specific of what goes on. So just because you have Parkinson's doesn't mean you have to experience dysautonomia, and just because you have dysautonomia doesn't mean you have Parkinson's. We see these kind of things within other brain conditions as well, such as like MS, spinal cord injury, brain injury. They can all kind of be very closely related as well. And so what is dysautonomia aside from it doesn't work? It's still kind of a phenomenon. We don't understand a ton about it. There's a lot of research on it, but there's nothing that specifically says, yeah, this is what it is and we know how to fix it. We just know it's a neurocardiological interplay between your nervous system and your cardiovascular system, and it's something that happens that leads to orthostatic hypotension, which is a funny way of saying you get lightheaded because your blood pressure drops. And that's the most common complaint is low blood pressure. And we'll kind of go a little bit more into that later too, but that's the most common cardiovascular sign of dysautonomia. There's other signs too, because your autonomic nervous system interplays with your bowel and bladder, your GI system, as well as your breathing, your heart, things like that. So you can get all sorts of different signs. And then the other thing that we found with dysautonomia in persons with Parkinson's disease is the aggregation of the protein alpha-synuclein, which is commonly referred to as a Lewy body, is that protein buildup in the brain. And that basically leads to autonomic denervation, which means the autonomic nervous system is losing connection with the rest of the body. And that is what is widely observed as the link in Parkinson's disease. But there's no specific culprit as it relates to Parkinson's, which sucks because we want to know why we're dizzy and kind of how we can fix this. But there's a lot of research being done about what can we do with this, and hopefully we'll explore that a little bit more later about what can we do to hopefully aid this in people with Parkinson's that are experiencing this level of dizziness. So, and how I like to explain it to patients is ultimately dysautonomia is a software issue. So yeah, we know there's a hardware issue with the loss of dopamine in the brain, but that is leading to now your brain can't process appropriately. It can't run the software, which is leading to kind of a host of symptoms. Okay, so those are kind of the main things with like primary associated related to Parkinson's. There's a lot of other complex things that we can talk about too. And if you have questions about that, happy to answer them. But those are the main things that we see clinically and what the research is kind of talking about right now. The other thing that we see clinically is kind of what we're going to call the secondary association, and that's related to the treatments of Parkinson's. So deep brain stimulation and medications are the main ones. A lot of you have had both or maybe just one of those. And I'm sorry to disappoint you here. These are not my areas of expertise because I am not a physician. So if you feel like one of these areas is going to play an impact in you, you really need to talk to your physician about it. If it is something I can fix or another therapist can fix, then we're happy to do that. But these are largely controlled through physicians. But hopefully you just get a better idea. The other thing that really sucks about the DBS, in a preliminary research, there's not a ton that talks about specific dizziness as it relates to people with Parkinson's with DBS. And so you can do deep brain stimulation in a bunch of different areas of the brain depending on what you want to treat. Dizziness is a common side effect, but there's nothing that points to why specifically we're experiencing it or what can you do about it. It's most commonly complained to, or brought up to like therapists after an adjustment or an initial placement. And mainly it's because your brain's still adjusting to things, and so it's going to take some time to really let things settle down and for you to adapt to the changes that are being made. Ultimately, if you are experiencing this system or these issues, I flip my DBS on and wow, I'm getting kind of dizzy, you need to mention that to your neurologist so that you can get the appropriate settings that work for you guys. Or maybe it's a whole other issue that might seem like it's your DBS, but it's something else. I just had a patient the other day, they truly felt as their DBS, and then when they went back to the doctor and they said, no, I think it's a medication thing, and then they fixed the medication and bang, it's fixed. So the important thing here to remember is if you feel like it's an issue, you really need to bring it up so that we can get it explored. Medications. If you've done any Googling on WebMD or Google in general about side effects of a medication, you're going to see dizziness as a side effect for literally every single medication, which doesn't help us any. But with the Parkinson-specific medications, the most common one that we're familiar with is carbidopa-levodopa, or Sinemet. That's a notorious culprit for causing low blood pressure or that hypotension. I stand up, I get dizzy, or nauseousness. and therefore people might perceive that as dizziness. So that's the main culprit, but all the other Parkinson's medications, such as the selegiline and the entacapone, those can do it too, and if you're on multiple of these, then you're running a higher risk of kind of running into your dizziness. So aside from Parkinson-specific medications, if you have high blood pressure and you're on a blood pressure medication, guess what? You're probably going to get dizzy because it's trying to lower your blood pressure. And if you take that interaction with the Parkinson's medication, you're probably going to have some dizziness. Now, again, I'm not a physician. I can't tell you what to do with your medication. So if we feel this is an issue, you need to bring it up to your doctor so that we can get it addressed, okay? The other things that may or may not be related to Parkinson's that you can still experience, because guess what? You're still a human, and Parkinson's doesn't define your life, and so you can still experience other things that aren't related to it. And I think this is important to remember too. As a healthcare provider, I've been guilty of it, that someone comes in, they say I'm having dizziness or imbalance. They say, oh, it's related to your Parkinson's, and it's not the case. It could be something else too. And so this is my message to both you, caregivers, patients, other practitioners, that we need to be looking kind of beyond the Parkinson's too, to see, is there something else that's contributing to your symptoms aside from just Parkinson's or Parkinsonisms? Some examples might, like we've talked about, the orthostatic hypotension. You stand up too quick, your blood pressure drops, you get dizzy. There's what's called postprandial hypotension. I didn't know this was a thing until I got to PT school. This is when you just get done eating and you get dizzy. Has anyone had that? No, because I don't want to move after I get done eating. So I didn't know that this was a thing, but it is. So just keep that in mind. There's what's called BPPV, or vertigo. Some of you may have heard this is when the crystals are moving in your ear, or the inner ear. There isn't I guess, huge link to this in Parkinson's, but there is a huge link to it as we get older in general, as well as with head injury, osteoporosis, vitamin D deficiency, stuff like that, which living in the lovely Midwest, we're all kind of known to have a vitamin D deficiency. As we get older, we're more susceptible to osteoporosis, so therefore the vertigo or the crystals in your ear become quite prevalent as we get older, okay? Not to worry though, that is a relatively easy fix in the world of dizziness, to get the crystals fixed. So if you feel like that's an issue, go see a physical therapist, we can work on it. Other vestibular conditions like Meniere's disease, or just like one side of your vestibular system isn't working as well, or brain injuries can also contribute to these. Say you have a fall because you experienced a freezing episode, you hit your head, that could cause quite a bit of dizziness, more kind of like what we consider maybe like a concussion or something. Not directly related to Parkinson's, kind of a different condition, but still making you dizzy, okay? And like, just to bring it back to what we talked about earlier, you can have any three of these kind of categories interact with each other and cause your dizziness. So you may be experiencing dysautonomia, which is directly linked to your Parkinson's. You may be experiencing dizziness secondary to the medication you're taking. And you may be experiencing dizziness because you have crystals loose in your ear. You combine those three things, and now you can understand how challenging it gets. Let's think back to that picture of the guy with all the strings going crazy, because that's what it looks like to us, is, what is the issue here? And so that's where people that work with this stuff kind of get pretty good at dissecting it and seeing what exactly are the issues and what do we need to do to treat it, okay? But it's not always clear. So what's the moral of the story? Dizziness is immensely complex. Again, it can interact and come from many different forms and many different causes. We know that persons with Parkinson's have a higher risk of experiencing dizziness due to just the nature of the disease course itself, the treatments, as well as you're still human and can still experience other things. Okay, and the other thing I just want to be really clear on is your dizziness may or may not be related to your Parkinson's. It doesn't have to be. So don't ever, again, we're not going to just blame everything on Parkinson's. It could still be something else. So what can I do, or what can you do to address this? And the biggest thing as a healthcare provider is when you come into the clinic and say, I'm having dizziness, we're going to ask you a bunch of questions. It's like, when does it happen? How long does it last? What makes it better? What makes it worse? When did this start? All these questions. And if you come into the clinic knowing all that information already, then we can get right to the bottom of it really quickly, okay? So either caregivers or persons with Parkinson's, if you are experiencing dizziness, keep track of it, I get dizzy an hour after I take my medication. I get dizzy every time I stand up. I only get dizzy when I lay down in bed. You know, different examples like that. What do you think is associated with your dizziness? Keep track of things that help or things that make it worse. You know, does just sitting still make it better? Does laying in a dark room make it better? Does medication make it better? And what makes it worse? Kind of those triggers again. How long do symptoms last? That is a big one, because if your symptoms only last a brief 10 to 30 seconds, we kind of know where we want to go with it. And if you say, no, I'm kind of just dizzy all the time, that's a little bit more of a complex story that we're going to kind of have to really explore. So really make sure you're specific of how long is it lasting, or is it different feelings of dizziness? You know, I get dizzy at this time of day and it feels like this, and I have a different type of dizziness that feels like this later in the day. And then when did it start? You know, is this just kind of been a lifelong thing? Is it progressive, or is it, no, just a week ago something happened and now I'm really dizzy? Those are important things to note too. So if you come into your a visit with either your doctor or your nurse practitioner or a therapist, massage therapist, wherever, and you're saying, you know, I'm having these symptoms, and if you tell them this, we're going to know what to do quicker and get you feeling better quicker, instead of kind of have to play the referral game. Okay, and then ultimately, I think we see this more clinically, is sometimes people are afraid to even bring it up. You know, they feel like, oh, I got all these issues and my doctor's kind of hearing from me. Don't just let it sit there. You know, bring it up, talk about it, because if you don't, then you're for sure going to continue to experiencing the symptoms, and that's definitely not going to get fixed. So we need to kind of talk about these things and explore these things to get better treated. You know, I didn't have a slide in here about this, but the other thing that from a physical movement standpoint, we know with Parkinson's, your movement are slower, it's tougher to move, and therefore we kind of move less, which is why therapists and doctors were always on you about, you need to keep moving, you need to keep exercising, doing all these things, because that helps keep your sensory integration, remember the eyes, the ears, and the nerves in your feet, all working fluidly together. The minute you stop moving, your brain thinks, oh, I no longer need to process that information, and so over the course of time, weeks to months, when you go to move again, you're going to feel a little dizzy because it's kind of new to your brain. Your brain literally quite forgot how to process that information. So that's why we're always, always, always on you about we need to keep moving for a variety of reasons. But relative to the dizziness, that's what we think too. We want to keep you moving because it's going to decrease your risk of dizziness too. Here's some references for a lot of the studies we did. That is all I kind of really have to cover. I'm happy to answer questions, and ultimately I just want to thank you all for supporting the South Dakota Parkinson's Foundation and coming here and kind of learning more. Hopefully you guys learned something and connected with a lot of people. And mainly I want to thank you guys for getting up every day and choosing to live well with Parkinson's. You know, it's a very unique and difficult journey, and you guys are all amazing at doing it every day. So happy to answer any questions if anybody has anything.
Are you aware of any studies of people that have the orthostatic hypotension that later develop Parkinson's?
Not that explore the direct link, no. I mean, I think if you take a large enough sample of people and you look at, okay, these people started experiencing lightheadedness in their 40s, how many people develop Parkinson's? There's too many variables to consider to say that there's a direct link, you know, because there's medications, there's geography where you live. We know in the Midwest there's a higher risk of Parkinson's just due to environmental factors, and so there's too many variables to rule out to establish a direct link. Yeah.
Does tamsulosin or finasteride interact poorly with carbidopa-levodopa?
That's a great question for your doctor. I don't know. We learn pharmacology, but in terms of the specific interactions, that would be a better question for your physician, absolutely. You got to yell at Steph to take big steps.
I'm curious about what you said toward the end there, that the more you sit, your brain forgets how to process the information. So if you've been sitting a long time and you experience the dizziness, will that come back again if you continue to move after that?
Yeah, when I say you've been sitting a long time, I more or less mean like chronic sedentary activity, months on end where you're just really not moving. If it's a day here and there where you're not moving, yeah, I mean, I know when I'm kind of a couch potato and I lay down all day and I get up, I'm a little off for a little bit, but certainly, your brain is still, even in the presence of Parkinson's, your brain is very moldable, very plastic. It can still learn and improve things. And so, if we have a patient who hasn't been moving for months on end and we get them on a therapy program and we're moving and moving, yeah, we certainly expect improvement, absolutely.
Hey, Colton. If you suspect that it might be a BPPV issue, crystals in the ear, any problems with trying a home epi maneuver before going down a path of whatever else? Can you try that? Is there any harm in trying it first?
The only harm is it just might make you dizzy. And what I always tell people, if you're going to try a home, so what she's talking about is the epi maneuver is something to help move the crystals back to where they belong with the BPPV. That's kind of one of the gold standard treatments. I always tell people to educate them on how to do it appropriately. There's a lot that can kind of go wrong with an epi maneuver, and so if you're not doing it appropriately, it may not be effective. It's certainly not going to harm too much. It might make you more dizzy. And of course, there's always a risk, when we're talking about the vestibular system, there's 3 canals each side. And if you're doing an epi maneuver, which treats one specific canal, there's a chance that crystal converts into a different canal. So then the epi maneuver is no longer going to be effective. And so those are just considerations to do. But oftentimes with my patients, I'll see them in the clinic, we'll do a couple things, and if I can't see them for another week or 2, yeah, I'll have them do a home epi maneuver, absolutely. And most of the time they feel it's beneficial, as long as we're doing it appropriately. That's the trick. That's it? Okay. Well, thank you so much, guys.